representatives. One way the School of Nursing then is celebrating its anniversary is to offer these opportunities for faculty members of different schools to engage each other on issues relevant to healthcare and relevant also to broader university interests. Hopefully in the context of a constructive collegial discussion, yes, okay, with a view to deepening the sense also, though, of APU's strengths and opportunities to pursue its own mission. Today's topic is the Affordable Care Act, also known as, familiarly as Obamacare, one of the most contentious political issues in this season of our nation's run-up to the presidential election of 2016. Our two speakers are well positioned to get us thinking afresh about these issues. Dr. Tulleners Lesh, Ph.D. and RN, is professor and dean of the School of Nursing and has a dynamic record of educational, intellectual, and pragmatic support of nursing in any number of cultural and political contexts. Dr. Jennifer Walsh, Ph.D., is dean of the College of Liberal Arts and Sciences and professor in the Department of History and Political Science, and has written extensively on the need to cultivate political activism on behalf of the welfare of our society. Though it may come as a surprise to non-nurses, and I see there are some with us here today, nursing actually has a long history of political activism. Nursing has always been very clear about what it's supposed to be doing, namely to save lives and improve them. And it's in the context not merely of medicine or recovery from illness, but the much broader parameters of general human health and well-being, of individuals, of families, of communities, of cities and states, the well-being of nations and of the world. And occasionally, political realities will then determine the avenues of, or lack thereof, for nursing to accomplish these deeply worthwhile goals. Florence Nightingale, at one juncture of frustration with the British government, wrote, "If we choose to please the government, we will no longer please God. For what is pleasing to the House of Commons is not at all pleasing to God. Oh dear, if only the Lord could be king, or at least the Prince of Wales." Please welcome first Dr. Lesh and then Dr. Walsh.
Well, it's interesting to follow Florence Nightingale. She's just an amazing woman. Thank you. I also need to recognize Dr. Dave Dorman and his committee, who were the inspiration behind the 5 dialogues that were scheduled. And I'm hoping that there are flyers out there for the subsequent dialogues, which should prove to be very interesting. So today we're here to talk about the Affordable Care Act, and I can honestly say I do not think there's a single person in this room who has not been touched in some way by these changes. They have been profound and deep. Let me just recap briefly, just provide a slight introduction to the Affordable Care Act, and then I'm going to turn it over to Dr. Walsh to speak about the political aspects of it. But on March 23, 2010, President Obama signed the Patient Protection and Affordable Care Act, now known as ACA, and the initial legislation was 995 pages. One of the remarkable things about where we are today is that you can go anywhere on the internet and put in that title, and the entire document will come up. It used to be that we would never have an idea of what was in that. Now, the second challenge is, of course, to read 995 pages of the Affordable Care Act. As Dave mentioned, this was extremely contentious legislation, heavily debated, mostly along partisan lines, and this has continued even after passing. Almost immediately, there were challenges to its constitutionality, particularly the concept of individual mandate and the mandate to provide Medicaid coverage by the states, even, and I guess at that point in time, the jeopardy was their current Medicaid allocation. The Supreme Court has agreed to hear that case and came through with a decision that I'm sure Dr. Walsh will speak about. But the result was that ACA continued and that the impact of the legislation is not only national but statewide as well. Each of the states are now faced with multiple decisions that leads to carving their own path through ACA. California, one of the earlier adopters, is relatively far down the road in its implementation. And one of the biggest challenges that's looming currently on the horizon is the rising cost of funding the expansion of Medicaid. A daunting and sobering accounting will increasingly become more urgent for the constituents of California. The second compelling issue in the Affordable Care Act is, did it do what it set out to do? How has it impacted healthcare system? How has it impacted the quality of healthcare? And has it become more cost effective? What does ACA really mean for true access to healthcare? Following Dr. Walsh's presentation, I will try to talk a little bit about the impact of the healthcare system and the changing landscape as a result of ACA. And I must say that as I started to list out the things that have been impacted, I found more and more and more areas to address. So I know I will not cover all of them, but I'm hoping to hit the highlights. Dr. Walsh.
Well, good afternoon. It's good to see everyone here, and I'll try to keep my remarks relatively brief. For some of you, you've been following this closely in the news because you're a voter, and you pay attention to the news, and you pay attention to politics, and this is something that you care deeply about. For the others of you, perhaps you've only been engaged on the margins, and now with an election year coming up and the candidates once again turning to major social welfare policy debate, it's time to kind of refocus on the Affordable Care Act. So for those of you who have been living with it for a while, it's been actually around in the news since 2009. This was when President Obama was first newly inaugurated in 2009. He made it one of his pivotal pieces of legislation in his new first-term administration. In a special address to a joint session of Congress, he challenged Democratic leaders who were in control of both the House and the Senate at the time to take up this initiative and give him a bill he could sign. And so that spawned about a year's worth of ongoing discussion and debate. It didn't culminate until 2009 at the end, December 24th, Christmas Eve, last day before the Christmas recess, that the Senate was able to deliver a vote in favor of the Affordable Care Act. For those of you, again, who've been following this closely, you might remember that this was a contentious discussion, in part because it invoked all sorts of discussions about the proper role of government, whether or not this was appropriate for the federal government to do, whether or not this should be left to the states, what the role of the private market ought to be, how the individual decisions for health care would be made in light of a government payment system. And then on top of that, we had burgeoning concerns about the deficit and the amount of debt the United States was taking on just to maintain its Social Security and Medicare programs that were already ballooning out of control. So to complicate things, you had some people who had voted for the Medicare drug expansion program back when President Bush was in office, and had found that the Congressional Budget Office had woefully underestimated the costs for that law. And so there was concerns that the cost projections for the Affordable Care Act would also be inaccurate, and what that might mean for our federal government's deficit. The political machinations, if you will, resulted in not a single Republican vote for the Affordable Care Act. And that's a first. In all other major pieces of social welfare legislation, they've been passed with bipartisan support. Maybe not enthusiastic bipartisan support, but nonetheless, both Republicans and Democrats have come on board with those initiatives. The last major health care one was back in 1965 when Lyndon Johnson signed into law the Medicare and Medicaid bills that created the program that we have now. So the December 24th vote was significant because during that 9 months of active deliberation, There were town hall meetings staged, especially over the summer recess when congressional members went home to visit their constituents, and they were hearing a lot of concerns from voters who were afraid that their doctor choices might be limited, that the single-payer system that we had heard about in Canada and Great Britain that had resulted in what was perceived as substandard care would also be then implemented into the United States. And because we have a reputation for having one of the best healthcare systems in the world, there was a lot of concern about what that might mean for families and individuals. And so members of Congress got a lot of feedback from their constituents, and that made some Republicans reticent to sign on, even for those who recognized that there probably needed to be a role for the federal government to play. Well, in the meantime, Ted Kennedy, who had been a longtime supporter of universal health care, passed away from cancer, and Scott Brown, a Republican, was appointed to replace him. Scott Brown was able to win a special election. It was actually a special election, and he did that by repeatedly tweeting that he would be the vote to break Obamacare if when elected. He was appointed, and then he was facing an election confirmation in the new year. So in order to avoid that, the Democrats rushed through in the Senate a version of Obamacare Affordable Care Act that they probably would like to have modified, but because Scott Brown was scheduled to take office in January, they knew that they didn't have a chance once he were in office. And the reason for that is because Republicans at the time were threatening a filibuster, and even though Republicans now are in control of both houses of Congress, the filibuster looms large. And basically what that has resulted in is the need for 60 votes to get anything through. And if you can't get 60 votes to pass, then you are likely out of luck. So Scott Brown's threat to be that 41st vote, or the 59th, they would be losing by one, was enough to spur them into action. So when Obamacare, or Affordable Care Act, was signed into law, what we found is that there were a couple of issues that needed to be resolved by the courts. And the Supreme Court has taken on two major cases and upheld the Affordable Care Act in both cases. And then there's one scheduled likely for this year, although they haven't officially put it on their calendar. So the first challenge came resulting in whether or not this was an expansion, an unconstitutional expansion of congressional authority. Did Congress have the constitutional right to intervene in the healthcare system? And that's not a trivial question because we have a system of limited government, unlike other democratic nations which allow their legislatures to have broad areas of influence in a variety of different fields. We have intentionally limited what Congress can and cannot do in the Constitution. It's Article 1, Section 8 that describes the can and can't do list. And of course, healthcare was not even conceived of back in 1790 when the Constitution went into effect, but it certainly is today. And so they asked the question before the Supreme Court: is this an unconstitutional use of power? With Justice Roberts being the swing vote, the Democratic majority plus Roberts was able to uphold the use of authority in that decision a few years ago. And in doing so, Roberts explained that Congress has a broad power to tax. And because there's a fee associated with not purchasing health care, and that there are corollary pieces to the Affordable Care Act that stem from that ability to tax people for certain things, that it was in fact an appropriate use of power under Article 1, Section 8. The most recent case came last June, and so King versus Burwell asked the question, if the subsidies that were provided to participants under the Affordable Care Act were unconstitutional, given that most of the subsidies were given to federal exchange participants. And I know Dean Lesh is going to talk a little bit about the state and federal exchanges, but there, again, maybe perhaps not as critical of a question, but there was still some concern about the language and the appropriateness of the statute and how it was being implemented, whether or not the federal government was doing something that it was not authorized to do by the law. And again, Justice Roberts, writing for the court, said The goal was to provide additional health care benefits for people without insurance. And so if we were to take a very narrow reading of the language that said that only applies if you're in a state exchange, not in a federal exchange, it would undermine the intent of the law and the whole thing would become moot. And perhaps some were hoping for that result, but that wasn't the case. And so the Supreme Court once again upheld the Affordable Care Act. And looking forward to this year for the Supreme Court, they are going to be taking a case that will probably affect a number of faith-based organizations. If you recall, one of the questions that came up early on in the law's passage was the mandate to provide birth control for all participants, that every employer-based program or any private insurance offered under the Affordable Care Act system would have to include a broad array of services. Access to contraception and contraceptive devices was required. And a number of faith-based organizations filed objections to that, saying that it would infringe upon their religious liberty and their right to maintain a free conscience. That might resonate with what Dean Lesh will likely be talking about is the lack of competition in the market. We're seeing mergers among insurance providers. So much so that there's a concern about price controls and whether or not this was going to force prices to go up. We know from other industries that when there's a lack of competition or only a few partners in a particular industry, that it's easy to monopolize prices and consumers often suffer. There's concern about the Cadillac tax, which is likely to hit in 2018 unless Congress intervenes. And that will affect a larger number of people than initially anticipated. There's also the price differential that causes premiums for younger patients and subscribers to increase. Previously, most states allowed a 5-to-1 ratio where older subscribers could be charged 5 times the amount of a younger subscriber. The Affordable Care Act dropped that to 3-to-1. So it meant that for younger people, healthier young adults, their premiums went up substantially, 40% more under the new system than the old system. And as they're facing increasing fines for not purchasing insurance, they're likely to want some relief for that. And then other structural reforms include some, we have to do something with Medicare. Right now, in the next 10 years, Medicare is projected to go over $1 trillion in spending. And it is going to, as we have, increasing aging population, it's going to take on more and more of our federal budgets. We have about 1/3 of patients can't get doctors under Medicaid, Medicare because of the lack of compensation for them, and many doctors view it more as charity work than anything else. So there's discussions about whether we should convert Medicaid, Medicare into a block grant program, privatize aspects of it, or somehow provide some other price relief. So I guess I'll stop there. There's much more we can go into detail, but maybe we'll pick up in the Q&A with some additional thoughts. Thanks.
So what I would like to address is the systems change that's been happening. And this, the ACA had both intended and unintended impacts on the healthcare system. And I can only say that the healthcare system has been profoundly impacted in ways that we're only just now beginning to realize. Most of the history of healthcare is that it was not market-driven, and this has changed. And so one of the things we're seeing is that there are healthcare organizations that are floundering that never used to be in difficulty before. What are some of those changes that are contributing to this major upheaval in the healthcare systems? First of all, the state reorganization that took place. What happened as a result of ACA is that there was a major restructuring of all healthcare provided under the state of California, in moving everything into healthcare per se. And so one of the first things that happened in 2013 and 2012 was that drug and alcohol was moved under health care. This has been followed by mental health. And we see a major consolidation at the state level of all the healthcare providing organizations that used to have their own domain. Now, the initial argument was essentially that this would curtail overhead costs, but in essence, it has resulted in the provision or the restructuring of mental health and drug and alcohol treatment and many other healthcare provisions more along the medical model rather than some of the more social welfare models that they had before. The immediate result of that was that there was an intense state focus on small organizations throughout the state that they felt were essentially defrauding the Medicaid system. The Department of Health Services had multiple small agencies for example, in Los Angeles County that were providing drug and alcohol treatment services. In 2013, 200 of those agencies throughout the state were closed, and the implication was that they were all defrauding Medicaid. The reality is that many of them were struggling with an inadequately funded system of care and were cutting corners, so to speak. But the Medicaid fraud is a substantial business. Yesterday, the district attorney's office in LA alleged that a doctor and 14 associates took part in one of the largest insurance scams in history, and the cost was at $150 million. So we know that fraud is a big concern as these organizations are consolidating, and the push is towards larger and larger institutions. So the changes in the elimination of the small and individual provider has a broad impact in Los Angeles. Right now, it's very hard to get Medi-Cal drug treatment anywhere. Currently in the Los Angeles County, there is a major merger that's undergoing in which public health, drug and alcohol, and Department of Mental Health are moving under the Department of Health. And this has been approved. This is moving forward. And we anticipate that over the next year, all of those will be sort of controlled by a separate board that oversees all of them. They're not essentially merging their systems yet, but that's only a short step down the road. The impact of these larger healthcare organizations that is massive in that the appeal process, the interaction process, the ability for an individual to interact with their systems becomes more and more complicated. Changes in physician practice, this is moving very rapidly, and for many organizations, this is already, I think, a horse that's left the barn, so to speak. The merges, the IPAs that are being structured, there's merges of physicians, and we are losing individual physician practice at an alarming rate. We anticipate that over the next 5 years, there will be no individual physician practices. Essentially, they will all be formed into physician IPA groups of practice. And that has both positive and negative impact. IPAs are able to then negotiate with hospitals and insurance at a different, with some power, whereas individual physicians are finding that they have no power to negotiate rates or reimbursements. The impact of hospitals sitting on the board in a local hospital, I'm faced with it at every board meeting, but the impact on hospitals has been also dramatic. Hospitals are being faced with increased legislation in terms of both the expectation of specific outcomes and the penalties associated with not meeting those outcomes, both at a federal and the state level. The second area that they're feeling increased competition on is that they are very much driven by physician practice in terms of the physicians bringing in the patients. The discussion now is that patient lives are really the domain of the IPAs and the insurance companies, and that unless you have a large physician group that has control over patient lives, you are not able to actually sustain sufficient patient contacts and patient presence in your hospital and your hospital beds. And so a number of smaller hospitals are starting to close their doors as a result of this. You will also see that hospitals are merging into larger and larger organizations, and this has been looser organizations such as the merger between UCLA and Huntington Hospital and Verdugo Hills and a number of others in our local area but it's also been actually more, and more of them are moving into tight financial control. The intermediate managers of healthcare are emerging in a way that we've never seen before. So a good example is DeVito, who used to be, was basically a local entity that was in dialysis practice, purchased healthcare partners, and this purchasing is now being traded on the stock exchange as a company, and they are in business now of providing IPA, of being part of an IPA and providing healthcare throughout California. Those are big business corporations, and it's changing the practice of healthcare in our particular arena. Price shopping is the other thing that's becoming an increasingly interesting component, and that's also driven in many ways by the Affordable Care Act, and that is that hospitals are being asked to put the cost of all their charges available, to make them available to the public. Now, we do not necessarily have an informed consumer base that would really know, is it better to pay $50 or $5,000, and what do you get between the two differences? It's almost like getting your car fixed. You're sort of wondering, okay, $50 sounds really good, but what am I really getting for it? Do I really want the $5,000 price market? But the reality is that there's a strong push to allow shoppers to look at hospitals in terms of the kind of prices that they're charging, and the range is incredible. Not necessarily because there's any additional value added, but certainly because some have the reputation and the ability to charge more. The capping of salaries is a new and hot issue that's coming up in hospitals as well. There's been there's a bill in California now that seeks to control costs by capping the CEO's salaries, and you can imagine what sort of reaction that's been having. And we've had some interesting discussion on that as well. The integration of the data system is another huge challenge that they're facing, and this has drawn incredible amounts of dollars from healthcare, and both for the state and for the local providers. Healthcare providers, health plans, public agencies, all of them are being asked to integrate their systems for sharing critical information. And the exchange of health information, as we know, is not only regulated by HIPAA, but also by California law as well. There's many constraints on the sharing of information, and in addition to the legal ones, there's also the systems ones, in terms of we have multiple systems that have emerged that contain healthcare information that do not necessarily or readily talk to each other. And so we see an increasingly expensive option developing that of trying to systematize and integrate systems of care that were never meant to speak to each other. The challenges includes not only the cost of adopting and maintaining a healthcare information system, but to make it flexible and fluid in terms of the kind of demands that are being placed on it today. For example, Kaiser has spent billions of dollars putting their system into place. It's right now probably the state of the art in that it allows both a consumer participation as well as has tied in their network of healthcare providers, but it's still far from being ideal. The federal and state law regarding confidentiality have not been altered, and that's going to really create a major impact. The entrenchment of the separate systems and the difficulty of even writing the technology to have them talk to each other is a major impact as well. And, we know with our credit card information, we've worried about hackers. We know the federal government has been dramatically hacked by China, and there's a tremendous amount of information, including fingerprints and others that are now available. Healthcare systems, as they become more integrated and start to talk to each other, should be very worried about the possibility of the healthcare information of their participants being widely accessible as a result of hackers. some of the areas where it has really impacted nursing and some of the other healthcare providers is in the fact that it has opened up the door to multiple providers in other areas, to pharmacy, to optometry, to others, to really take, as well as to nurses, to really participate in being primary care providers. There is some pros and cons to that, but that, and there's certainly legislation that's needed to change nursing practice, for example, and pharmaceutical practices as well. But that is moving forward at an accelerated pace, and we'll see in the next few years that healthcare provision will have a very different, particularly primary care, will have a very different dynamic with multiple participants, and the challenge of really determining what is their role and what is their level of competence and how do we appropriately manage that for the consumers. Another area that has been sparked as a result of AC has been innovation. The Affordable Care Act depends on embracing new technology in order to reach more patients and in order not only to reach them but to treat them effectively and hopefully cost effectively. So there's good evidence that our technology is actually going to become a really positive partner with us, such as telemedicine, telehealth, mobile health, the capability of smartphone apps and technology. You know, I was at a lecture over the summer in which they demonstrated the use of the iPhone in order to use that as a stethoscope and then essentially an ultrasound machine, and to actually visualize the workings of the heart and to be able to diagnose with that in a very exciting kind of a way. Right now they can transmit EKGs, and so you do not need to be physically present in order to have your EKG. Then you can actually hook it up in the comfort of your home to your iPhone and transmit that way. The challenges on that is also the privacy of that information that's being transmitted. Interestingly enough, for cancer screening, the data that's coming out shows that a picture of a sore that you send out by your iPhone, actually the phone, the algorithm that analyzes the cancer is more accurate than most diagnosis by a physician or a nurse practitioner on that, and that we are actually it's a much more accurate diagnosis by at least they feel about 93% of them can accurately diagnose cancer, much better than what we do with our visual analysis. So there's a room for technology to really allow us to perhaps provide healthcare in a different and more exciting way. Kaiser is experimenting with a new model for the Clinic of the Future. They're rolling it out this year, in which you actually will go in, and as you enter the door, your card will identify who you are. You will be directed to prevention activities that you're supposed to be participating in. I know many of you may belong to Kaiser. You probably have already been bombarded by such things as, have you gotten this screening test and you need to go for this, or you need to get your flu shot and so forth. Well, they're setting this up in a formal way, and you will have opportunities for teaching, for education, for screening, and your healthcare provider will have all that information when you walk into the office to meet with them. The Uber model of healthcare is taking in an exciting way is taking place also, in that there's now several models that are out there, and we've talked about that within nursing, of where you can call up and you can request someone to come to your house to give a flu shot, to see perhaps a child that needs a simple examination and so forth. The other emphasis, the other change that is occurring is the shift from, and there's some interesting things we can talk about in terms of what's the underlying expectation or value system that drives that, but the self-management of care and the emphasis on prevention, self-management, and patient engagement are all coming together to look at different ways that we can actually turn the control of patient care over to the consumer themselves. many believe that empowering patients to actively process information and decide how that information fits into their lives and act on those decisions will be the driver of healthcare in the future. Technology is really helping to accelerate that, and evidence is growing that some self-monitoring activities can really be very helpful. And so we're seeing now things like biometric sensors, blood sampling sensors, tissue embedded sensors, epidermal sensors, wearable embedded sensors, external sensors that you could strap on. I mean, we can be monitored and wired literally for a multitude of things that that we can get feedback on and also provide to our providers. The other area, which is turning out to be a huge job market, is coaching, coaching for lifestyle changes. And this is not necessarily within the healthcare field, but people are now taking 60-unit worth of courses on how to motivate people and how to coach them into different lifestyles. Finally, I'd like to just talk about two other areas where ACA has had a huge impact on the system change, and one of them is mental health, and the other one is the care for seniors. Mental health is now, one of the things that was absent and that ACA has provided is very deliberate coverage for mental health treatment. As a result of moving into the medical system, which is the other driving force that's coming along with saying we will pay for mental health treatment, is that some of the medical models starting to be applied to mental health, which is quick fixes, behavioral changes that are rapid, and not necessarily geared for some of those issues. Special emphasis is being placed also on palliative care, chronic pain management, substance abuse, other areas that were initially not funded that are now receiving funding and are so coming to the foreground, asking for their share into the cost of delivering health care. And the cost is one of the things we're going to have to really talk about, because that's the big challenge that's looming ahead of us. The care for seniors is the other big challenge that's looming ahead of us. We know that there's been unprecedented growth in the senior population. California's senior population is projected to more than double to over 10 million in 2040, and we are not prepared to deal with that. There's significant regional variation in healthcare availability, in residential housing, in home health care, in hospice care, and the current rate of demand far exceeds the supply. So this is a huge challenge that we're not prepared to deal with. So at this point, I'd like to turn it back to Jennifer for a moment, because I'd like to talk a little bit about cost and the funding of it, and then maybe we can open it up for discussion, as well as perhaps talk a little bit about, what's the future hold for us in terms of the Affordable Care Act.
There we go. I think for most people, they're concerned about their impact on their premiums. For those who have employer-based health care insurance, we know that premiums have always been a source of concern as the amount we have to pay goes up and the amount the employers have to pay goes up, far exceeding the cost of inflation. So the Affordable Care Act was supposed to put some downward pressure on those costs and keep premiums under control for everyone, in part by pooling those who are uninsured. The thought was that it will relieve pressure on the emergency service systems, which is very expensive health care, but was often the primary care providers for people without insurance. So by giving them a primary care provider of their own, that it would somehow lessen the cost of emergency services, which are very expensive. But I think the core issue has really come down to how do we pay for health care as a whole? Just last July, a few months ago, the Affordable Care Act premiums came out, and they're looking an awful lot like private health insurance premiums, where some exchanges are posting 25% increases. New Mexico's state exchange posted a 50% premium increase. And so the Affordable Care Act's not looking all that affordable any longer, which is again causing a lot of voter angst for people who are just newly on the system. So I think the downward pressure on prices hasn't been realized, and perhaps part of that, if you listen to some economists, is that we have a fee for service that encourages widespread use without any kind of cap, and consumers are largely unaware of how much they're expending on healthcare. And I'll put myself in that category. I know that I have health insurance benefits. I know that when I go to the doctor, I have a $10 copay, and that's all I think about. But for those on the healthcare system, knowing how much that premium is and your deductible and how much each visit costs might affect consumer behavior, and that's ultimately what's going to be needed in order to keep costs under control, at least from the consumer side. So there's lots of issues with healthcare costs that we need to address, both on the pharmaceutical side as well as the provider side, and of course the insurance companies are often stuck in the middle. So I don't know how much time we're going to talk about it. We've had like less than 10 minutes, so we might want to turn it over to questions.